Hey, we're here at NASS 2023 in LA. It's October. I'm here with John Stark.
I'm the creator, inventor, and the orthopedic surgeon behind this method. I've been doing it for several years. The company is called Ilion Medical, I-L-I-O-N, which is a Greek word for woman from Troy.
Okay.
And it's related to the iliac, the bone that we're operating on. And the product is NADIA. NADIA is an acronym for neurovascular anticipating distraction interference arthrodesis, which
Okay.
is the way orthopedic surgeons talk about sacroiliac fusion.
With this large sort of cross-section, it's interesting that solution. Can you speak a little bit about the innovation and thought that went into creating that? And I guess also the approach that it's used to implant between the sacroiliac joint.
Sure. So the sacroiliac joint is a joint. It's a true joint that was ignored for about 100 years because we were focused on the hip and the degenerative disc, the herniating disc, and so on. And we didn't realize that didn't think about enough about that the sacroiliac joint, which is a movable segment, I'll do this, movable segment between the pelvic bone and the spinal bone, the pelvis. And so when we walk, this thing normally squirms and rotates, helps absorb shock and so on. The thing is that it's deep within the body, it's hard to feel, it's hard to image, and so with other things which are developed, total disc replacement and so on, the sacroiliac joint was ignored, and it became a cause of failure for lumbar disc surgery. They didn't even realize why these patients were getting better. They were filling up the pain clinics and so on, but they really had a degenerative process of this joint.
What you're saying is, in the cases of attempting to fuse like the L5S1, there was like complications with the SI joint?
Exactly. It happened two ways. In one circumstance, it was actually the sacroiliac joint, which in many ways looks like a herniated disc, even with the leg pain. In another way, the sacroiliac joint commonly fails as a result of lumbar fusion. It's our biggest group. It's about half of our SI fusions of people have had lumbar fusions because of the stresses are transferred to the SI joint and it wears out prematurely.
Okay, and they're getting like leg pain that you'd typically have with some lower lumbar nerve.
It has a very characteristic pain pattern, which is the side, off the side, and people can't sit comfortably. Whereas back pain from disc is typically in the midline, the sacroiliac pain is usually off the midline on the side and typically interferes with sitting. And so I saw this in my lumbar fusion patients. They came back and they had this atypical change in their pain, and we discovered that this is actually an outlier for lumbar disc problems. And probably, this is my theory, that it's probably the reason that lumbar spine surgery is imperfect in its outcomes and that a lot of people have continuing problems. It's not the lumbar problem necessarily anymore. It's now the sacroiliac problem, which is unmasked by the traditional surgery, and it stands out then as an outlier.
So then there's the solution of fixation for the SI joint, and you have this elegant implant that you're using, but also about the approach to the SI joint.
Sure. So if you're a trauma surgeon, and if a person has a complex fracture of this area, pelvis and the sacral bone, what they typically do is they come from the lateral side with a life-saving screw to hold this back together, reattach the limb. So it was a natural extension from some people to think that you could do the same thing from the sacroiliac joint. The problem is, with a fracture, it heals with bone-to-bone healing. And if you're going to apply such a technique to the sacroiliac joint, you still have interposed cartilage, and it doesn't heal the same way. So it never occurred to us that we would want to do that. Plus, of course, there's big arteries and nerves in this area. And if you're coming at right angles to those large structures, there's potential for injury, and we see those injuries. They're reported on the FDA website, the MAUD database. So I'm an orthopedic surgeon, and looking at a sacroiliac joint the way a foot surgeon might look at it, like there is a space behind the SI joint that you can safely reach from a traditional midline skin incision, and you can go into this point, like this, like that. You can introduce a guide pin into that point. Mm-hmm. You can follow radiologic landmarks inside of bone so that you are protected from all the nerves and vessels. And then you perform a series of steps. First, you find the radiologic landmarks. You create a little pilot hole. You expand that And then through a series of steps, you create a usable channel, and in that usable channel, you can put this implant.
Okay.
Now that implant is titanium core. Outside it's spray, it's hydroxyapatite and titanium plasma spray coated.
Okay.
And if you do that, can you see over here? The implant can reach the center of the joint, avoiding all this neurovascular structure. It can bring the relationships of the sacroiliac joint back to where they were originally, and then the bone will heal to this implant that way.
Okay. And I'm assuming also the larger cross section helps prevent point loads, because there's a lot of cancellous bone here too, right?
Well, our operation protects the cortical margins.
Okay.
In addition to the cancellous bone, which is underneath. That was a problem we had to solve, is that if you're sacrificing the cortex on the sacral side, you can get subsidence. And historically, in the distant past, we had that problem. Now we have overcome that with
And
our
I could make some assumptions about point loads with using a small diameter screw from the lateral side too, like
Sure.
Not just the anatomy.
Well, you want to restore this anatomy. You don't want the two bones to be collapsed against one another for a couple of reasons. One of them is that the redundancy of these tissues impinges on the nerves and vessels and so on. The other thing is, of course, if there's a deformity there, an orthopedic surgeon would want to restore that deformity to its normal relationship, and so that's what our procedure does. I was a general orthopedist, total hips, total knees, anterior cruciates, all that kind of stuff, all through the 80s. The MRI came out in 87, pedicle screw, spinal fixation came out in 87. So I started doing spine surgery of that type. Within a few years, I had a patient come back with unexplained severe pain of the type we're talking about.
Interesting.
Yes, and I surmise it was the sacroiliac joint, but nobody was talking about that. Somebody else did a surgery, didn't work out very well, but it developed an interest in me for recognizing the diagnosis. Because within the low back patients, there are people where the MRI doesn't make any sense, the MRI is normal, they don't get better after otherwise good surgery, or they get better for a while and then they go bad. Those are all sacroiliac type syndromes.
Interesting.
So I had to, as an orthopedic surgeon, apply orthopedic principles to finding a safe way into this region, which we did, and develop, first of all, the radiologic landmarks like you see here, so we could safely approach it,
Yeah.
and then the instruments to prepare the space safely, and that was done. The instruments were developed in 2007. We licensed it to Europe in
Okay.
2009. It's been around for a long time.
Okay.
The literature says it's safe and gentle, which is pretty remarkable for, this is the European Spine Journal, and their summary. And we believe that it is. We don't have the risks of bleeding, the risks of neurovascular injury. We can claim that we have a restorative element. The FDA allows us to say we have a restorative element, which is a big deal in orthopedics. Like total hips, you want to restore the anatomy. Like disc spaces,
Sure.
you want to restore the anatomy. And we do the same for the SI joint in this series of steps.
Have you found your peers to be receptive, to this concept and the application of your implantate?
When we get a chance to explain it to them, they're very receptive. There's been a tremendous amount of energy going into the SI area by the competing methods which come at it from the lateral side like this. The problem is they got through the FDA about 9 years before we did and spent a lot of money marketing that approach. Truthfully, it was not appreciated, that there could be such complications with the laterally based approach.
Sure. Mm-hmm.
So, yes, the word is getting out now.
So you have a badge here that says that you're FDA cleared. What was the timeline for that? Was that recently or?
It was 3 years. It took 3 applications. We got the CE mark in Europe in 2009, at the same time we applied for the first time to the FDA.
Yeah.
They did not understand the anatomic reduction thing, this orthopedic thing of restoration of anatomy. They understood compression, that was intuitive to them, but they didn't understand this. So 4 applications later, we got FDA approval just at the peak of the COVID epidemic in August of 2020.
Wow, way to hang in there. Geez.
Sort of true. Yeah, we got through it, and of course we were held back from introduction and education and all that kind of stuff through that period of time because of COVID, and now we're introducing, and there's great interest.
Well, that sounds awesome. And you're here at NASS. Is this How many times have you been able to show this at NASS?
Well, if everybody who walks by here, this has been done in Europe 7,000 times, and we've never had a neurovascular complication.
That's amazing. I mean, that's something you can really speak
Very
to.
proud of that, you know.
Sure.
And it's designed that way.
That sounds great. Do you have any plans for other trade shows that
We were at the Congress of Neurosurgery 2 weeks ago. The American Academy of Orthopedic Surgeons is about 6 months from now. But then I travel and I visit the surgeons to help them institute this. There's a lot to learn, even excellent surgeons, of course. There's some tips and tricks that we can show them, and it smooths things out. So I travel to do that. And plus, of course, we have Zoom conference, educational kinds of things. We take our models and explain the radiologic landmarks and the series of way the instruments work and all that. But yes, all of that is happening right now.
Okay. And I noticed you have some supporting graphics that you're displaying in the booth today.
You can see that the guide pin in this orientation would go all the way from the back in the skin all the way to the hip and never touch a nerve or a vessel. And that's built into this. And then if you notice these steps, there's a small channel cut, there's a distraction step, there's the instrument which protects the sacral side, and then after you have protected the sacral side, you create a larger channel in the implant, and there's a series of steps which gradually stretch the joint back to where it's supposed to be.
Oh, that's interesting.
Yeah.
So I see. You did mention that earlier. The idea of restoring the distance, and that makes sense.
It's very important, of course. Distraction is a key part of many orthopedic operations, correction of fractures or disc spaces that are collapsed or total joint replacements, and this is not different that way. If you distract the disc space, you want to get this in because it pulls the bones off of the nerves and so on. The same kind of thing happens in the SI joint.
Do you find this to be helpful for your presentation here?
It's indispensable. We show this because this demonstrates the progress of the case and the organization of the instruments. We have many other slides which show exactly how the nerves and vessels rest there and how it goes back. There's talks about the CT scan and how that's done and how they're treated preoperatively and postoperatively, all that kind of stuff. It's all available to the people who talk to us.
Okay, well, I really appreciated your time and
Absolutely.
your discussion, explanation too. You know, I've been around implants for sacroiliac joints, probably in the same timeline, and this looks like a really great solution. So I wish you all the best of luck.
Thank you very
and
much.
it was great speaking with you, John.
Thank you.